Our next speaker is Dr. Ronnie George, and he's the Deputy Director of Shankar Netralaya, Chennai, and again, very prolific glaucomatologist who's been a teacher for many. So let's hear from him on managing a failing bleb 2 weeks post-op.
So thank you for the kind invitation, Dr. Chitra. So I'm going to basically try and cover these things. So which are the things that I would look for about 2 to 3 weeks post-op as signs of fibrosis? One would be a shallow bleb, vascularization or increasing IOP. And I would also try to identify which is the site of fibrosis which is leading to bleb failure, whether it's subconjunctival or subtenons, whether it's subscleral, or whether it's a block at the ostium. So, and it's important that you assess everything in the bleb, the height, extent, vascularity, the intraocular pressure, and also very importantly, the feel. It's important to assess what the bleb feels like. Also, make sure that your ostium is open, because sometimes all the problem that you have is a little blood clot here. You massage a little bit and it will open up and there's nothing more needs to be done. So when I told you that in addition to assessing bleb morphology, please massage it. And when you massage it, you need to figure out, does the bleb increase? How easily does it increase? And to what extent does it increase? So this is a case, first case is about 5 to 6 days post-op. The anterior chamber is deep. The baseline IOP is 32. IOP now is 8 millimeters, and there's a shallow bleb with minimum vascularization. So now what's going through my mind is this may be a component of ciliary body hyposecretion, which you can get early post-op. So I do a gentle massage, and this is what you will see on massage. So what you can see is when I'm massaging there, the bleb does come up on your left side. You'll see a sudden bleb there, and you can also see the fluid leaking from there. So one of the commonest causes for an early bleb failure or early fibrosis is a bleb leak, because when you have a bleb leak, your conjunctiva will flatten out and you will get subconjunctival fibrosis. So any shallow bleb with a IOP which is unusually low, you should rule this out. And Dr. Devang has demonstrated well as to what we need to look at that. So this second patient is about 5 days post-op again. AC is deep, IOPs are 14. The bleb is fairly flat and vascularized. IOPs are still 14. Here you have to make sure that your ostium is patent, and we do a gentle massage. And what you can see with the gentle massage here is that the bleb is forming up fairly easily, not as suddenly as in the other patient, but you can see that it is expanding over there. So here the level of fibrosis is subscleral, and you need to start 5FU injections right now, because if you can manage to tide over this period, then you may not even need to release a releasable, and you can continue to have a good bleb. Now, this next patient over here, this next patient is a retrab, and what you're seeing over here is essentially, this is a previous trab, and this is a fairly vascularized bleb at about 2 weeks post-op. There is a significant elevation, but the intraocular come down with difficulty. So what can you do over here? The releasable is already released. You're trying to massage, and just watch how much difficulty I have with the massage. So here you have significant subconjunctival fibrosis. And if you leave this without managing to get an elevated bleb there, this surgery is going to fail. So here you will need to do an argon laser suture lysis in order to try and cut the remaining apical suture and start injection 5FU. Again, daily follow-up, and make sure you continue to massage. And this is what happened after the suture lysis. You can see a nice bleb come up there, and the patient is actually did fairly well with, and this is after about 3 5FUs too. This fourth case is 15 days post-op. The anterior chamber is deep. Intraocular pressures are 34 millimeters of mercury with a flat bleb. And now here I'm going to massage, and I'm going to just show you what is happening. So here with the massage, I'm not really feeling a bleb. I'm having to do a lot of massage there. And you can sort of see a little bleb forming. I continue to struggle with the massage. Then I decide that instead of doing a direct massage, I'll do an indirect massage. And with the indirect massage, you can see that the bleb is actually formed a little better. So what this tells you now is there is some flow through the subscleral space. You are getting some amount of, you're managing to balloon up the conjunctiva, but it's difficult. And here you need to either consider one of two things, either needling or home massage. You teach the patient how to do home massage, do daily follow-up, give repeat injections. If the patient is not cannot come for follow-up regularly, you need to consider needling. And this is another situation where you have somebody, this is a little longer than that, maybe 30, 35 days post-op. You have a nice elevated blood, IOPs of 34. It's encysted. And then what you would need to do is basically, again, the same thing, that is needling. And I'll just share with you this short video on needling. And this is basically not one of these two patients, but this is a patient with subconjunctival fibrosis, just like the first case. You can do this at the slit lamp or in the operation theater. And what you're doing here is using side-to-side movements to sort of free the adhesions that are there. And you can see the blood starting to form. I'm sorry, that video is. And you can see the blood starting to form now with the needling. You can see the elevation over here, close to the needle. And then after that, you go ahead and give an injection 5FU a little away from the blood. You may need to form the anterior chamber, which is why this is safer to do in the operation theater than in the outpatient, especially if you land up with a sudden overfiltration. So post-op blood management, early fibrosis is a tailored approach. You require a good rapport with the patient because you're doing all these things for the patient. The patient needs to be aware of what they can expect post-op. And I think it's important that you, I think I have 30 seconds. I'll just show you the argon laser suture lysis video. I wasn't sure I'll have time to do that. So this is basically a Mandelcon lens that you're using. You can also use the edge of a 4-mirror gonioscope if you want. Under topical anesthesia, you place the lens over the blood, and you basically, if you have massaged enough, you just require to be one shot, and you can see that suture just opened up. So essentially, you need to titrate your response to blood fibrosis based on the level, the duration of fibrosis, and what sort of follow-up you can do. So thank you.
Thank you very much. That was so methodically explained. Very basic question I'm going to ask you. When would you start advising a home massage? At what time? Would you wait for 2 weeks before you start, or you do it earlier? And can you just explain how the home massage should be done to the patient?
Okay, so there are two components to it. Now, if you look at the patient that I showed you, I had to struggle a fair bit to get that blood going. And in a patient like this, as long as I've ensured that there is no block in the ostium, I would even advise early massage, maybe 7 to 10 days. If, on the other hand, the blood is forming very easily, or I'm worried that there is a block there, then I would not advise home massage, because a very vigorous massage can land up with a shallow anterior chamber. And the first time the massage would be in the outpatient. I would make the massage, I would see what is happening. I would probably ask them to wait for a while and repeat it again. How you massage, there are, I think, multiple techniques. What I prefer to do is the indirect massage, where with the patient looking up, I ask them to massage steadily for a count of about 10 seconds, and then do 3 sets. I prefer not to ask them to do direct massage, which is adjacent to the blood, because when you give an oblique massage to the area of the flap, you can suddenly land up with a shallow AC. And if you are really, really rough, you can even cause a conjunctival dehiscence.
Yes. Dr. Harsh, Dr. Shushmita, would you all also advise that indirect massage, or do you feel sometimes only the direct massage will help in some cases?
So
I agree with Dr. Ronnie.
Yeah, I think Ronnie has really wonderfully covered every point.
Yes.
But like he rightly said, I first made them do it over there.
Yes.
And see if the lower lid massage is actually not elevating it enough, which happens sometimes.
Yes.
Then I'll tell them to look down and away, and then do the massage at the lateral quadrant of the lid, with patient looking down, press, release, and see it every single thing, that, okay, one press release, how much is the pressure? Another press release, how much is the pressure?
Yes.
And that really works wonders. And I really, because I just acquired an eye care, and it is so beautiful to have a rebound tonometer, because then you can actually, you can't do the application all the time and see what exactly is the pressure, and NCT is so unreliable in these cases.
Yes.
So you have to see which one is working well, and then make them sit like Ronnie said, if after an hour, check how much the pressure is elevated. So you can even titrate that after how much time he is going to do the massage.
Yes, I agree. Would you prefer 5FU or MMC, Dr. Shishmita, when you decide to do needling in these patients?
So we've always used 5FU rather than that. But then, like Ronnie said, you have to first identify where the block is and then plan. Because, of course, UBM is the best thing to do. But we've also learned clinically to look at the ostium. And what we've seen is if it's flat, it's just a small slit, then it's likely that there's subscleral fibrosis and not much fluid is going out into the subscleral space. Then doing a subtenons usually doesn't work. The subtenons works when the ostium is fish-mouthed. So if you see these fish-mouthed ostiums and you do a UBM, you see subscleral fluid very well. That's an indirect clinical thing that we've seen. But whenever we do a subtenons and we do it on the slit lamp, then I use 5FU away from the bleb, directed away from the bleb, and then massage throughout. But I'm a little wary of using MMC in the outpatient, which is a little uncontrolled. So I use 5FU.
Dr. Tanuj, do you have anything to add here? Dr. Krishna Das, a very warm welcome. Need your thoughts on it.
Thank you, Dr. Chitra and others. Very good evening. Actually, all the stepwise procedures Ronnie has covered well. And only I would differ with Sushmita that most of the patients we see when they end up with subconjunctival fibrosis, they already have significant glaucoma and require very low target pressures. And earlier I used to do 5FU, but now routinely I use mitomycin for all my bleb needling. And it's a good point. Most of these needling respond very well only when there is subconjunctival fibrosis. If the fibrosis is subscleral, most often it is episcleral rather than subscleral. There is a sheet of fibrous tissue that actually is on the surface of the sclera, and it doesn't respond to routine bleb needlings. In this case, what I do is I try to enter the anterior chamber with the needle blindly. And 50 to 60% of the time it works, and rest of the time we have to adhere to stepped up medical therapy or additional surgical procedures, depending upon the response of the intraocular pressure.
Dr. Tanuj, that was very useful, Dr. Krishna Das.
I think very excellent lecture by Dr. Ronnie. And I think just two additional points. One is that I would always prefer indirect lower lid massage, because with the patient, you are never sure of how he does, and there can be more complications. Secondly, whenever we do needling, I don't do it at slit lamp. I take the patient to the operation theater, because sometimes you can get shallowing of the AC and then you are very badly stuck. And thirdly, like if you are massaging and there is no elevation of the bleb, that means there is definite subscleral fibrosis. Then I would do what Dr. Krishna Das also mentioned, that it's like an ab interno needling. You have to go from inside the anterior chamber and go to the ostium and try to open the cleft or disengage the fibrosis. And that may lead to the fluid coming out into the bleb space. So sometimes you may even combine ab interno with the ab externo to get a clear picture. Having said that, the rate of bleb needling in literature, failure rate is very high. So 60 to 70% may fail over next 2 to 3 years. So you have to warn the patient that there is high risk of failure, and later on you may require to do a revision trabeculectomy. Thank you.
Yes, very useful points. I think it was a great learning in this.